I'm going to invite our next speaker who has come from abroad, traveled from all the way from America. He is Professor Dr. Bilal Ahmed, Assistant Program Director, Professor of Clinical Medicine, Wyoming County Hospital, New York, USA. The topic of his presentation is to do or not to do lessons learned from US healthcare system. Patient safety first. I invite Professor Dr. Bilal Ahmed.
Thank you. It's it's an honor to be a part of this August gathering. There's quality experts from all over the globe. Dr. Chima, you've woken us up with all those videos you made. It was better than the coffee I had outside. Just a brief introduction. I'm a professor of medicine, as you just mentioned. Thank you for that. I'm also the chief medical officer at this university hospital. It's in upstate New York, and also the chief quality officer for a string of hospitals associated with this hospital. So I was asked to talk about how quality is incorporated into the American healthcare system. I'm basically a pulmonologist as well as a palliative care physician, but this is a little bit out of my comfort zone, but I'm going to attempt. US healthcare system is complicated, and I think you read about that or hear about that in the news almost every day. I didn't check my Twitter feed this morning. Our president keeps on tweeting about healthcare. What I'll do is I'll make it a little bit like a TED Talk. I know the time is short, and I'll break it up into 3 equal parts. So what I'll do is initially I'll talk about a little bit about the politics of the US healthcare system, the cost associated with the US healthcare system. Then we'll talk about the structure for those of you who are not from America as to how is it kind of put together. And lastly, how quality is enmeshed into the delivery of the US healthcare. So, Randy Pausch was a cognitive scientist. He unfortunately died of pancreatic cancer, was an intellectual, and he said, whenever there's an elephant in the room, introduce the elephant. So here you go. So this is our president. So he was elected based on a promise that he's going to really shake up the healthcare system. And he said, you're going to have such a great healthcare system for a fraction of the cost, and it's going to be so easy, and I'll do it in a few days. Well, a few weeks into his, after he was elected, he said nobody knew healthcare was this complicated. Well, who knew? But here we are. This is the other end of the spectrum, and as I stopped kind of looking at the news in September 12th when I was preparing for this talk. So this is the candidate who wants to come in the next election. This is Bernie Sanders, and what he's promising is that he's going to have what's called Medicare, which is kind of like the National Health Service in the UK. He's going to make that available for the whole country. Now, I have to say, it may come as a surprise to you. There's a social hierarchy in all societies. That's the nature of a human society. You have the House of Lords and the House of Commons here. There are people who watch cricket and people who watch soccer, and never the twain will meet. They don't talk to each other. In the US, you'd be surprised to hear that one of the ways that people kind of look at each other and they have these kind of bubbles in the society is, what kind of a healthcare insurance do you have? So do you have one of the employer-based healthcare insurance, or do you have Medicaid, which is for the poor, or you have no insurance? You will find these people are isolated, they don't talk to each other. So one of the ways people kind of put this strata in the society is because of the kind of healthcare insurance you have. So that's a hierarchical thing, and healthcare really is not a right, it's a privilege. Imagine in a country, in an industrialized nation, the richest country in the world, your healthcare is not a right. Now with that, it may come as a surprise to you that in spite of that, US spends the most amount of money on healthcare compared to any other country in the world. So about 18% of their GDP, which is about, their GDP is about $20 trillion. Can you imagine that? 18% is spent on healthcare. And there's a lot of studies, if you spend more than 20%, then you don't have enough money to spend on infrastructure, on education, on defense, so you will have an unviable country. So they're almost getting up to that point. If you want to look at it a little differently, they spend about $10,000 per person per year on healthcare, and compare that to UK on the left, which is about $3,000. So you're spending about 4 times as such, but are you getting 4 times as such? Actually, no. When you look at on the right side, This was a Commonwealth study, and they looked at the top 13 or whatever industrialized nations and see how they did in effective care, efficiency of care, and timeliness of care. And US was at the rock bottom of all these industrialized nations. Now you may ask me now if I can step off the podium and get lost, because what do I have to teach you? Because we are at the rock bottom of this list. But you know, all systems have they have good things about you. We can learn from each other. So I'll talk a bit about that. Just to kind of bring you, give you a little framework of what the healthcare system is. So the U.S. has a number of parallel systems which are going together but not so together. The U.S. veterans, as well as the Native Americans, as well as anybody who's above 65, they have something akin to the Nationalized Health Service here. A majority of the people, apart from those people, have what's called employer-based health insurance. And then there's some people who have no insurance. So if you have no insurance, what do you do? Well, no, I can tell you stories. I saw a patient just a couple of weeks ago. A young man, a pizza delivery guy, comes in. We're having acute chest pain. We do an EKG. He's got ST segments and he's about to die. And I said, I'm going to send you to this university hospital, which is right next to where I'm seeing him, to get you an angioplasty. And he says, no way, I have no insurance. What you'll do is you'll send me there, I'll get it done, but you'll come back and you'll get the money out of me. He said, just give me something and just send me on my way. This is the richest country in the world, and I had to give him some aspirin and whatever, some medications. I knew he was going to die. He probably did die. Can you imagine that? That's what's happening. So this is the other kind of the dirty secret in the United States no one talks about. This is called the Dartmouth Atlas. So what they did was they looked at the different postcodes or zip codes and saw how much healthcare costs to be delivered in a particular postcode. And as you can see, it's very different. So where I am at the top right, it's about $5,000 per year per person. But there's places in the country where it's $10,000 per year per person. Why is that? Well, they have something called the charge master. So all hospitals, all systems have an algorithm. So I'm kind of like the Darth Vader, and they kind of see how much can you spend on healthcare. So if I'm in a rich neighborhood, my hospital is going to charge me more compared to a poor hospital, a poor neighborhood hospital. But that is just the way it is, and that kind of adds to the cost. So at the end of the day, really why it costs so much is because the US does not have a universal healthcare insurance. As the country's name suggests, United States of America, it's an aggregation of states. They have different laws, they have different cultures, everything's different, and they don't agree on anything. So they cannot have a unified healthcare system just because of that fact, because it's a number of states kind of all hitched together, and they cannot agree on anything. But one main thing which is causing this increased high cost is that most of the healthcare insurance is private. So if you talk to a private health insurer, who are they going to be beholden to? It's going to be the shareholders, not to the patients. So it's all about profit. There's also a huge amount of technology. You just saw some videos about robotic surgery and all that. We have these robots in every little hospital throughout the country, even where you don't need them. So there's a lot of technology, and because of that, there's a huge expectation. So if you have a person who has got a good healthcare insurance, the concept for an average American is, we have all this technology. You just saw Yuri Gagarin. You just said, we have been to the moon. We don't deserve to die. We're never going to die. They expect never to die. And one of the facts which is leading to that, it's a kind of a tongue-in-cheek, have it all, is direct to consumer marketing. So there's hardly a country in the world in which the drug companies and equipment manufacturers are going to advertise on the TV. So if you've been to the US, and if you switch on the TV, about 30% of the ads are going to be some infliximab and rituximab and some kind of a Tarceva and whatever they ask you to go to your physician and ask for this medication because it's going to be cure-it-all, like a snake oil salesman of yore. In fact, in England, it was banned back in the early 1900s, and it still goes on in the US. And then people's expectations go up, and they want more and more and more, and that adds to your healthcare. This is my hospital. On the bottom left, I took this picture about a week ago. As you can see, everybody's congregated around the computer screen. The patient is just missing in the picture. Everybody looks at the computer screen. That's where the labs are. That's what they're treating. They're treating the labs. They're treating the X-rays. They're not treating the patients. Up on the right, we have these in our hospitals now. We call them docs on a stick. So I know we're going to talk about telemedicine. But there's telemedicine going on within the hospital. You don't really need that. But there's a lot of technology. And all of that adds to cost. So I'm going to actually now switch gears a bit into what is quality. So this conference is about quality, and I want to make it very, very simple. It is meeting the needs and exceeding the expectations of those we serve. That's all quality is about. That is all that you have to remember. So meet the needs and exceed the expectations of those whom we serve. So I'm actually going to tell you a story. Stories stick with us. We are physicians. We are born to listen to stories and react to stories. So this is a true story of a patient of mine, and I wrote about him in New York Times. It came in about a year ago. And then I'll link it into patient quality. So this was actually a man who worked for the Ringling Brothers Circus. It's a circus. He's an elephant trainer. So this circus is coming to my town from Boston, and he complains of the most severe headache of his life. So he comes to the emergency department. He gets seen by the nurse, and I'm kidding, but maybe I'm not kidding, is that if you end up in an American hospital and if you complain of anything, the first thing they'll want to do is a CT scan, MRI scan, some kind of a radiologic imaging. I sometimes half jest to my emergency medicine chief is that, we should have a scanner outside as the ambulance pulls in, because, you're going to do it anyway. So he says he's got a headache, and they do this MRI scan. As you can see, they say, oh my God, he's got an enlargement of the lateral ventricle, and this has got to be an obstruction in the foramen of Monroe, and everybody agrees, and now you have this image. Now you're putting it together to this patient's complaints, and so everybody says, so this is the anchoring phenomena, the heuristics of anchoring, and confirmation biases and ascertainment bias, so all that comes into play. So they say, all right, let's put in a stent in the foramen of Monroe, which costs about $20,000. They got the stent, they got the neurosurgical team, the operating room was ready for him. This is when I walk in the morning, and I say to this person, I said, can I see you before you go down? And the transporter's outside. He wants the patient to go down right now because it's all about flow. It's all about flow in US hospitals. And the man is angry. He says, so many people have seen me. I don't want to see another doctor. I said, please, can I just see you? Because I have to write my note. I have to just make sure I'm doing the right thing. So very grudgingly, he puts the blanket down, and he actually has herpes zoster, which is causing his pain. And I said, does anybody see you? He said, no, they didn't see me. So nobody's seeing the patient. They're looking at the image and putting the image into the patient's presentation. And then I call the neurosurgeon. I say, hey, this guy doesn't have what I was going. You think he's actually got herpes zoster? They get angry at me. They say, well, the whole team is here. We've got this $20,000 stent. We've got our drills and everything to go into his skull. So you're telling us he doesn't need surgery? I said, no. So they're upset at me. So back to quality. As far as the hospital and the physician's concerned, we did fine. We did excellent. So we have the door to triage time. We have the time to be seen by a physician, time to do an MRI scan, time to consultation. We did fine. The metrics were all met. But what about the patient? He had an unrelieved headache. There were bright lights, a noisy room. He had a squeaky stretcher. He got the wrong diagnosis, and we were going to go into his brain. So he wasn't happy. So the quality at the end of the day, whatever metrics we talk about, it's by the patient's bedside, and that's what I want to kind of talk about today. All right, so what I'm going to do here, I'm going to show you this video towards the end, because I think, as we talk about quality and metrics, and Dr. Chima was talking about surgeons and the metrics attached to the surgeons, fine, we need to have all those metrics, but it's also about the patient. So just very briefly, we talked about that. I mean, this is the nature of what the healthcare insurance is these days. About half the country has insurance through their employer. I have to say, this is a bad concept. So I have insurance through my employer. I get sick, and I cannot come back to my job for like 6 months, and I lose my insurance. What use is that insurance to me? So this insurance doesn't even help me in a catastrophe. So really, the system is broken. And what the Republicans are now saying, they want to give us choices. So they want to give us money back through our taxes so that we have more choices. We can go buy insurances. But sometimes choices don't matter, really. I mean, this poor guy is getting two buckets. So everything changed. So I'm going to shift gear now to the last part of my talk, is that everything changed in 1999. what happened was the Institute of Medicine came out with this report. It's called "To Err is Human." So we all make mistakes. So they said, we've been talking about the wrong thing. We've been penalizing physicians. We are looking for mistakes and we are punishing people. It really is not that. It's the systemic errors within the system which lead up to mistakes, which is very, very true. So what happened was they equated that. So this is another cognitive science kind of an idea, is that when you equate an example with what you're trying to say, we remember that, or you equate a story with what you're trying to say, you remember that. So what they said was, we're killing so many people because of medical errors that is equivalent to about a jumbo jet crashing every other day. And the whole nation woke up. They said, what do you mean a jumbo jet crashing every other day? So many people are dying due to medical mistakes, which is true. So they said, we have to do something about that. So as you kind of look at it another way, the amount of people dying due to medical mistakes is the number 3 highest cause of death in the country right now after heart disease and cancer. So what did they do? So they said what we can do is that we can actually shift towards a process improvement rather than punishing people, and we also have to link pay to performance. So it was all about, we get paid, there's all this thing about US doctors get paid a lot of money, which is true, but people get paid because of the number of procedures that they do. Now, all of that is being changed to your performance and not to the number of procedures that you do. So this started this concept of what's called value-based purchasing. So I think it is important for the listeners here to listen to this, is because we're talking about quality. So this is all about quality. So how do you attach value to what you do? So what they did was they kept back it's now about $5 billion. So $5 billion is kept back, and it is paid to people who do a good job. So you can actually lose money up to -2% of what you make annually for not meeting the metrics, or you can actually make +4% for meeting the metrics. So there is a lot of value in the system now, which is attached to performance. Now what they do is there's bonus payments for care processes, there's bonus payments for patient satisfaction, there's reduced payments for errors, for readmissions. I can give you an example. The elder Bush, the President Bush, he got admitted recently for COPD to a hospital. He was treated, given antibiotics, sent home, came back within 2 weeks, and the hospital wasn't paid for the readmission. Because now they say that if the patient gets readmitted within 30 days, it's the hospital's fault, and we're not going to pay you for that. So you better do a good job. So all these bonuses and reduced payments are now built into the system. They're baked into the system. Right now, there are 4 domains in the value-based purchasing. And as you can see, one of the things that I like about this is the patient experience, which is about 25 to 30%. So what happens is every patient who sees a doctor in the US, in the outpatient setting or in the hospital, gets a questionnaire. So they get mailed a questionnaire, and the question asks them about, was the doctor nice to you? Did they talk to you? Did they talk to you in a language that you understood? Did they explain what they were trying to say? Was the nurse nice to you? Did they care about your medications? Did they explain the medication? So there's about a set of 38 questions. So that comes back to the centralized system, and my data is visible to the whole country. So we were just talking about transparency. So there's that amount of transparency to individual physicians, which is actually being mentioned by the patients whom I see every day. So there's these outcome measures, as well as processes of care measures. And as we go through the years, what's happening is you can see it shifting. So this is 15, and now in 17, it's more about efficiency. It's more about the patient experience. It's more about how much do I spend on my patients. So I think it's moving in the right direction. And money talks. So all targets for 2017 that were set by the centralized medical services have now been met. This is the survey that the patients get. Every patient gets that, and as you can see, the doctor questions. The doctor treats you with courtesy and respect, listens to you, explains things to you in a way that you understand. So I think that's very good, because that takes it back to the patient's bedside. And this is reportable. This is reported on the internet. You can go to Medicare.gov. You can look at your doctor. You can look at your hospital. You can look at everything. So everything's very transparent. What is also done is that we have a metric madness. There's so many metrics that we have to meet now, but I think a lot of them are well-founded. So we just kind of pay attention to the one that really are making a change. Yes, so I'm actually going to I'm going to stop here, and I'm going to show you a video, and because I think that is important, because I really want to bring compassion into this. And so again, my last message is, we could talk about quality all day long. At the end of the day, it's all about the patient. So we really have to think from their perspective, feel their pain, see what they see. Only then will we end up in the right place. So I can, if there's any questions, I'd be happy to answer now or at the end of this session.
I think we'll take it.
Okay, right, okay.